All right, hi everybody. This is on. Okay, so my name is Rahul. I'm a cardiologist and co-founder of Atman, the software company that is building software to be able to enable management of chronic disease. So, even though there's been a number of advances in medicine in the last decade towards treating diseases like type 2 diabetes, high blood pressure, high cholesterol, depression, we're still terribly poor at achieving what we would say is precision in care. And in this case, what I mean is matching treatments to patients in a way that achieves excellent clinical outcomes at low cost. And so why is that? There's unfortunately a lot of reasons. And one of them is that even though there may be very good guidelines on what we should be doing, actual physician decisions are incredibly variable and expensive. And yet, one large study looking at heart failure patients found that only a third of patients after about 2 years were on the right medicine at the right doses. And moreover, even when you move from clinical trials where things seem to be effective, when you move medications into the real world, all of a sudden there's this dramatic drop-off in efficacy. And one of the reasons for that is that many of the sort of most vulnerable populations are not even studied in trials. So we have to sort of suffer that kind of fall-off also. And then finally, the legacy workforce, which includes people like me, are not so nimble when it comes to new workflows and actual new therapies. And so one very good example of that is the sort of great new medications in type 2 diabetes. Even about a decade in, we still don't see routine use at all. So our solution has been to take this on somewhat greatly by building software that fully automates all of the decision making and treatment steps that are required to manage these chronic diseases. And so the process for this actually ends up sort of fundamentally redefining what the care model is. So the top shows the traditional model, which is what we have as a typical care provider or physician making sort of the types of decisions that you would expect. And in this case, our software sits squarely there and really does all of those things that need to be done. So medication selection, initiation, titration, side effect handling, automating the documentation, and really handling a lot of the sort of adjacent conditions that a patient might have. And that achieves two things. So one of them is that all of that variability I talked about is gone. And that everything is sort of implemented in a very, very systematic way. And the second is that new evidence that comes in can get implemented almost immediately. So there isn't that sort of like lag between where things change and, oh, I don't remember what that is, maybe the typical kind of delay just doesn't happen. But the second thing that this introduces is an ability to shift a lot of this work that is incredibly tedious to actually get patients to goal, which has very little to do with the kind of initial order, has a lot more to do with sort of being able to bring somebody along the way to that. And that shifts to a care navigator. And these care navigators become an essential part of the system and an extension of the software so that they're really carrying out what are the tasks that are needed. And then the physician is able to focus really on the things that licensed providers need to be able to do. And so since this is an AI platform, we have to sort of bring in the AI element, which is that beyond those things, which in themselves are sort of substantial, what you have here is the ability to build a kind of reinforcement learning framework into the way in which treatment decisions are optimized. So rather than sort of being stuck with whatever it is that's sort of the existing decision making, you actually have, some of you may recognize this sort of the Barlow and Sutton model for reinforcement learning. You have your agent, which in this case is the software, produces decisions which are around medications, doses, intervals in which they're changed. And then you have a patient that's there that sort of has a patient state, which is changed by the medication or not changed. And that's determined or predictable by many of the things that are there in terms of comorbidities, social determinants of health, race, prior responses. And then the reward here is time to goal. So really you have this loop here. Individual patients can kind of rapidly iterate through in terms of new treatments so that they can actually get quickly to goal. But separate from that is you have a system that learns and then figures out, okay, how to do this better the next time around. And so rather than sort of being stuck in kind of legacy guidelines, you actually can kind of not only implement them, but surpass them. So just another view of this, and the only thing I'm going to highlight here is that if you have a broad enough rule, which in this case is time to goal, there's many levers you can actually influence in this. And so they're not just medication doses and timing, but actually also responses, biomarker responses, behavioral strategies. All of these are sort of fair game because they're also systematized, so that all of that sort of, that sense that you can't control any of those, all of those can actually be optimized towards getting to that same goal. So, when this actually gets implemented, and this is sort of real data, all of a sudden a lot of the things that have been historically unsuccessful can now move to being very, very effective. And so normally we'd say that maybe only about half of patients get to some degree of goal and usually can take 1 to 2 years. We see this typically in months and more in this 85 to 90% range. And I think the thing that's more exciting in my mind is not only is that effective, but that very quickly within 4 weeks or so, you can actually start to surpass existing guidelines. So you can see what isn't working and bring that knowledge back. And so the proof of that is really that in one of our deployments, about a third of the patients at goal are actually on a bunch of medicines that the guidelines would not have said would be the first line ones, and that's just because those didn't work. And so we were able to rapidly sort of learn what does work and be able to implement that. And then overall, this sort of system with the navigator doing a huge amount of the work ends up being some substantial projected cost reduction, and also just because the outcomes are just excellent. And so we have already deployed in a number of different settings. We have a pilot with the United Health Group in Detroit, focusing largely on the under-resourced Medicaid population. We're at the other end of the spectrum in a concierge clinic in Southern California. We'll be going in University of Colorado Health pretty soon in terms of cardiac and diabetes. And then the sort of the precedent for all of this is within the Harvard hospitals itself. We're doing about 10,000 patients pretty much. And some of that work has been published. So our roadmap in the next few years, because we built the platform so that it's sort of very flexible, we're adding multiple new diseases. We have 3 already right now. We're going to add pulmonary disease, or cardiac disease, behavioral health, rheumatology. So all that is being built up because we're finding that that's sort of what people want, is the breadth rather than having single verticals that are not talking to each other. There's also more and more machine learning being built on the platform itself, and we're moving more and more data to the patient themselves so that they can be self-care efficacy. So as one might guess, with an aging population, there's a huge number of people who have these conditions. And what we really focused on is the sort of value-based care setting, because ultimately that's where it pays to get people to goal and low cost. Because unfortunately, a lot of medicine is fee for service and nobody cares. It's kind of going through the motions. But if there's actually a carrot and a stick, then you actually get much more incentive. And so there's a number of patients that are sort of it's expensive to take care of them, but in these value-based care contracts. And then there's a considerable amount of shared savings that can be passed on to the provider if you actually get patients to goal and you're able to do that at low cost. So again, we're focusing, there's a whole lot of flavors of physicians and provider groups out there. We're focusing initially on those for which there are very well established guideline-based programs. And so this is my last slide, just sort of describing who we are. So we have a good deal of bravado here that we can overhaul much of how chronic care is done. But to do that, you need a pretty diverse team that has a lot of experience on the clinical side too, but also experience on the machine learning side and on the technology side to be able to scale and pull this off. So this is our team, and I think we may have a couple of minutes to take some questions. Happy to answer anything.
Yes, rapid fire. Here we go. Nice. Right over here.
What is the main way that you see this product connecting with the actual patients? It seems like there are a couple different ways that you're working with different providers, but
yeah. So that's a great question. I think we kind of glossed over that a little bit, but the software enables a care team, a remote care team that does everything. So meaning that they're sort of taking things off the plate of the original provider level, kind of like a specialty kind of referral system. And the patient then is managed by the team, but the navigator being the kind of core person they're interacting with. And then then there's a little bit of hierarchy there in terms of sort of somebody with a license on top of that. But the software ends up driving sort of all of the things. So it's not like, hey, the navigator just does some ancillary stuff to coach, and the licensed person does their own thing. It's actually sort of very, very integrated because it's only scale, so that you can sort of get the numbers that you can get to just by having that. So it's sort of taking, it's analogous to, I don't know if you do this sort of the analysis is sort of taking stuff off the plate, fully managing it, and handing back somebody who's touched, rather than lots of back and forth, which we think is not particularly appealing to existing providers. They want to log into a new system, they don't want to estimate. This is the pace of exchange has never been. So it's pretty fast and not something that's easy to accommodate in the current workflows.
Okay, we got about 1 minute left.
It's not clear to me when you say the navigator team, is that part of your software, or is that
Yes.
a bit there as a kind of
Yes, another great question too. It's sort of this whole idea of, are we tech-enabled services or are we software? So what we've had to do to start with is be the users of our software. So we are the team. That isn't the model we want. We typically, what we've been seeing with some of these sort of early customers is they already have medical assistants. They have people who sort of have already been on staff and sort of this role. We would provide training, but ultimately we don't want to be in the personnel business as much as we want to be. And we see that we will provide some degree of consult support, but we don't want to be in the business of staffing that. But early days still require us to